Hi, I'm Dr. Robert Settipane. I'm a practicing medical doctor and MD, specializing in allergy and asthma for over 30 years. My specialty board certification is in allergy immunology. Allergists who specialize in allergy immunology are asthma experts, not to be confused with ears, nose, and throat surgeons, ENTs, who overlap with regard to also treating the upper respiratory tract. ENTs are sometimes referred to as allergists, but the specialty of otolaryngology does not include asthma as its specialty focus. There are two medical specialties that focus on asthma, and these are pulmonology and allergy immunology. However, any physician or healthcare practitioner can diagnose and treat asthma, so specialty certification is not required to manage asthma. This video is about considering the question of whether people with asthma are at greater risk from COVID-19. Are asthmatics at increased risk? If they are, what can be done to reduce that risk? Because COVID-19 is so new, there's not enough data to make a definitive statement about the relative risk for people with asthma. However, there is enough perceived risk for the Centers for Disease Control, the CDC, to include asthma or people with asthma among those at high risk for severe illness from COVID-19. Specifically at risk are individuals with moderate to severe asthma. Despite including moderate and severe asthmatics among those at high risk for severe illness from COVID-19, the CDC states that there are no published data to support this determination at this time. Neither is there evidence of increased COVID-19 infection rates in those with asthma. The CDC website states people with asthma may be at greater risk of getting very sick from COVID-19. However, this higher risk applies only to individuals with moderate and severe persistent asthma, and currently does not apply to individuals with mild persistent asthma or intermittent asthma. The CDC warns that COVID-19 can affect the entire respiratory tract, including nose, throat, and lungs. It can cause an asthma attack, and it may possibly lead to pneumonia and acute respiratory disease, including ARDS. Similar to the groups identified by the CDC at high risk for complications from the common flu, the CDC has identified multiple groups at high risk for severe illness from COVID-19. These groups include people age 65 and older, people who live in a nursing home or long-term care facility. Other high-risk conditions include people with chronic lung disease or moderate to severe asthma, people who have serious heart conditions, people who are immunocompromised, including cancer patients, people of any age with severe obesity, and pregnancy. These groups are all considered at higher risk from COVID-19. There is a very strong argument that if you have persistent asthma, now is the time to get serious about achieving optimal control of your asthma. So please try to follow along as we review asthma severity categories and the guidelines for the appropriate choice of asthma medications. Asthma is a disease that affects your lungs. It typically causes repeated episodes of wheezing, shortness of breath, chest tightness, and coughing. Asthma can be controlled by taking medicine and by avoiding triggers that cause an asthma attack. Asthmatics must do their best to avoid and remove the triggers in their environment that can make asthma worse. Asthma triggers can be irritant or allergic in nature. Irritant triggers include airborne chemicals, dust, and any form of smoke, including secondhand tobacco smoke. Allergic triggers can include mold spores, pollen, animal dander, and dust mites, which are found in bedding, fabrics, mattresses, pillows, upholstered furniture, and carpets. For asthmatics who are allergic to animal dander, avoiding asthma triggers may include avoiding exposure to common pets. Infection triggers of asthma typically include a wide variety of respiratory infections, including the common cold, RSV, and the flu. Social distancing is an effective mechanism to avoid viral respiratory infection triggers of asthma, including infection with COVID-19. That is why social distancing and frequent hand washing are important for everyone at this time, especially moderate to severe asthmatics. The National Heart, Lung, and Blood Institute is recognized as the national authority on asthma management. The NHLBI is the third largest institute within the National Institute of Health. While the focus of the CDC is disease prevention, the focus of the NIH is application of biomedical research. In 1991, the NHLBI released the first expert panel report on the guidelines for the diagnosis and management of asthma. The most recent expert panel update, EPR3, was issued in 2007. A new update is expected later in 2020. These expert panel guidelines are the product of the nation's top asthma experts. These guidelines are the most reliable guidance for the diagnosis and management of asthma. So let's review what the NHLBI guidelines recommend regarding optimizing control of asthma. Compliance with NHLBI asthma guidelines can optimize lung function and decrease both the frequency and severity of asthma exacerbations, including exacerbations triggered by viral respiratory infections. Therefore, it is reasonable to infer that compliance with NHLBI guidelines might offer some protection against the possibility of a COVID-19 triggered asthma exacerbation by decreasing the likelihood and the severity of a COVID-19 triggered asthma exacerbation. The NHLBI guidelines classify asthma according to severity and provide treatment guidance for each category of asthma severity. The two broad categories of asthma severity are intermittent asthma and persistent asthma. Intermittent asthma is mild by definition and typically requires limited use of rescue inhalers. Rescue inhalers are typically short-acting beta agonist inhaled medications such as albuterol. Persistent asthma is characterized by more frequent and typically more severe symptoms. The NHLBI asthma guidelines recommend that persistent asthma be treated with daily use of one or more asthma controller medications. Optimization of asthma control requires that individuals with persistent asthma be identified so that they may be prescribed daily treatment with asthma controller medication. Therefore, it is important to review the asthma guidelines to determine which individuals have persistent asthma. A review of the asthma guidelines also provides valuable guidance to optimize asthma treatment for each category of asthma severity. Here's the definition of persistent asthma according to the NHLBI guidelines for ages 12 and older. If you meet any of the following criteria, you have persistent asthma. So, during the past 2 to 4 weeks, have you experienced asthma symptoms greater than 2 days per week on average? Nighttime awakening from asthma greater than twice a month? Any interference with normal daily activity? Short-acting beta-2 agonists, rescue inhaler use for symptom relief more than 2 days per week. This does not include the use of such inhalers for the prevention of exercise-induced bronchospasm. That is separate. Do you experience asthma exacerbations requiring oral systemic corticosteroids, such as prednisone, more than once a year? If you meet any of these criteria, you have persistent asthma. FYI, the criteria for moderate persistent asthma include the following. If you meet any of the following criteria, you have moderate persistent asthma. This includes asthma symptoms occurring daily, nighttime awakenings occurring 3 or 4 times a month, some interference with normal daily activity, short-acting beta-2 agonist use, rescue inhaler use daily for symptom control, not the prevention of exercise-induced bronchospasm, and FEV1 or peak flow between 60 to 80% of predicted or personal best of peak flow. If you meet any of these criteria, you have moderate and perhaps severe persistent asthma, and the CDC advises that you are at increased risk for severe illness from COVID-19. The assessment of asthma severity considers both the level of impairment and risk. However, asthma severity is assigned based on the most severe category in which any feature occurs. Impairment is assessed based on the patient's previous 2 to 4 weeks and by spirometry and or peak flow measurements when age appropriate. NHLBI guidelines are that all asthma patients meeting criteria for persistent asthma should take daily asthma controller medication. Here is a definition of not well-controlled asthma for ages 12 and older. Based on the previous 2 to 4 weeks, if you meet any of the following criteria, your asthma is not well controlled, and additional asthma control medication should be considered. Have you experienced in the last 2 to 4 weeks asthma symptoms greater than 2 days per week, nighttime awakenings greater than twice a month, any interference with normal daily activity, short-acting beta-2 agonists, rescue inhaler use for symptom relief greater than 2 days a week, FEV1 or peak flow between 60 to 80% of predicted or personal best, asthma exacerbations requiring oral systemic corticosteroids more than once a year. Reflecting back in the previous 2 to 4 weeks, if you meet any of these criteria, your asthma is not well controlled. Similar to severity assessment, the level of asthma control is based on the most severe impairment or risk category. Impairment is assessed based on the patient's previous 2 to 4 weeks and by spirometry, peak flow when age appropriate. Asthmatics who meet criteria for persistent asthma will require treatment with 1 or more daily asthma controller medications for optimal asthma control. All asthmatics who meet criteria for poorly controlled asthma may need to start a new controller medication or increase the dose of their current controller medication. All asthmatics should consider enhanced avoidance of asthma triggers before increasing daily medication. Let's review asthma medications. The first category of asthma medication is rescue inhalers. Rescue inhalers give quick relief of asthma symptoms. All asthma patients, regardless of their type of asthma, should be given a prescription for a short-acting beta agonist for quick relief of asthma symptoms. Short-acting beta agonists include various generic and brand versions of albuterol and levalbuterol. Albuterol is not considered a daily asthma controller medication, but merely gives quick, short-term relief of asthma symptoms. Rescue inhalers are also prescribed before exercise for persons with exercise-induced bronchospasm. Asthma controller medications are the next broad category of asthma medicines. These are daily, long-term control medications. The expert panel recommends that long-term control medications be taken daily on a long-term basis to achieve and maintain control of persistent asthma. Leukotriene receptor antagonists are one type of asthma controller medications. LTRAs, as they are referred to, are oral medications most commonly prescribed as tablets and also chewable tablets for children. Montelukast is the most commonly prescribed medication of this type. LTRAs can enhance asthma control while providing the advantage that they attenuate exercise-induced bronchospasm in some patients. However, the expert panel considers them less effective as asthma controllers than inhaled corticosteroids. It is important to be aware that montelukast can occasionally cause a mood alteration side effect in some patients, resulting in anger, depression, suicidal thoughts, and vivid dreams. Individuals experiencing these side effects should not continue to take montelukast. Inhaled corticosteroids are the next broad category of asthma controller medications. The expert panel concludes that inhaled corticosteroids are the most effective long-term therapy available for patients who have persistent asthma, and in general, inhaled corticosteroids are well tolerated and safe at the recommended dosages. Studies demonstrate that inhaled corticosteroids improve asthma control more effectively in both children and adults than LTRAs or any other single-ingredient long-term control medication. However, the dose of inhaled corticosteroids should be titrated to as low a dose as needed to maintain good control of asthma. The dose of inhaled corticosteroids can also be titrated higher when greater asthma control is necessary. The expert panel advises that the dose-response curve for inhaled corticosteroid treatment begins to flatten for many measures of efficacy at low to medium inhaled corticosteroid doses. Most of the inhaled corticosteroid benefit is achieved with relatively low doses, whereas the risk for adverse effects increases with higher doses. However, some data suggests that higher doses may reduce the risk of exacerbations. Inhaled corticosteroids can be combined in the same delivery device with long-acting beta agonist when a greater degree of asthma control is necessary than that provided by inhaled corticosteroids alone. There are multiple ICS plus LABA combination inhalers available by prescription in the United States. They are typically available in various potencies. Generic versions of these products have recently become available and prices have come down substantially, especially when using prescription discount coupons such as those from GoodRx.com. The expert panel also concluded that ICS plus LABA combination is more effective than the combination of ICS plus LTRA tablets. However, the addition of an LTRA might benefit asthmatics who are inadequately controlled with inhalation of a combined ICS-LABA. The addition of a long-acting muscarinic antagonist inhaler, a LAMA, can also provide additional asthma control if inadequate control is not achieved with more traditional asthma controllers. For the most severe forms of asthma, new biologic medications may be necessary to achieve adequate control of asthma. These biologics for asthma are typically prescribed by an asthma specialist. Severe exacerbations of asthma may sometimes require short-term systemic treatment with oral corticosteroids. Drugs such as methylprednisolone, prednisolone, and prednisone are prescribed for 3 to 10 days to gain prompt control of inadequately controlled asthma. Asthma patients who are prone to severe exacerbations are sometimes prescribed a supply of oral corticosteroids to have readily available to self-initiate treatment of an acute asthma exacerbation. To summarize, the CDC has identified groups at risk for severe illness from COVID-19, and these groups include people with asthma, particularly people with moderate to severe asthma. Therefore, it is especially important for these asthma patients to keep their asthma under the best possible control at this time. Following the NHLBI Guidelines for the diagnosis and management of asthma will optimize asthma control, thereby decreasing the frequency and severity of asthma exacerbations, including exacerbations triggered by viral respiratory infections. Asthmatics should avoid irritant and allergic triggers of asthma. These include all forms of smoke exposure, dust mites, and sometimes household pets. Asthmatics meeting criteria for persistent asthma should be prescribed one or more daily asthma controller medications. Asthmatics meeting criteria for not well-controlled asthma may need to start a new controller medication or increase the dose of their current controller medication. Inhaled corticosteroids are the most effective long-term therapy available for patients who have persistent asthma. Inhaled corticosteroids are well tolerated and considered safe at the recommended dosages. Taking action to optimize asthma control offers some protection against a COVID-19 triggered asthma exacerbation by decreasing the likelihood and the severity of such an exacerbation. Regardless of the COVID-19 threat, it is always prudent to optimize asthma control by complying with NHLBI asthma guidelines. You may need to contact your healthcare provider to obtain a new prescription for one or more asthma controllers. Additionally, all asthma patients should have a prescription for short-acting beta agonist rescue inhaler for quick relief of asthma symptoms. Asthma evaluation by your healthcare provider can determine if you have persistent asthma requiring daily asthma controller medication. Evaluation may include pulmonary function testing and allergic sensitivity testing to aeroallergens. One of the best things a person with asthma can do to protect themselves is to achieve and maintain good asthma control. It is especially prudent at this time for asthmatics to take the initiative to obtain medical care that will enable them to achieve optimal asthma control. If your asthma is currently not well controlled, call your healthcare provider and schedule an appointment to optimize your asthma control. Many providers are now treating patients by telemedicine over the telephone. We are doing the same in our offices, so you may not need to appear in person at your provider's office. I am located in Rhode Island, where our governor has issued an executive order mandating that insurance companies pay for telemedicine and sometimes waiving co-pays for telemedicine visits. However, the Rhode Island mandate only applies to established patients. Therefore, patients who are trying to initiate care with a new provider may have a more difficult time. My understanding is that only Medicare will pay for a new patient telemedicine visit. Therefore, it may be more difficult to obtain medical care as a new patient at this time unless you have straight Medicare. You may need to make multiple phone calls to secure an appointment to be seen as a new patient. Persistent asthma patients who have asthma controller medications should continue to take them. Persistent asthma patients who do not have asthma controller medication should do their best to find a healthcare provider to prescribe asthma controller medication. Recent federal and state mandated telemedicine coverage may facilitate access to optimal asthma care. It is up to you to find that care and optimize control of your asthma.